Cor pulmonale. This is defined as enlargement of the right ventricle, dilatation and/or hypertrophy, due to increased right ventricular afterload caused by diseases of the lungs, chest wall, or ventilation control center. Primary diseases of the pulmonary circulation, e.g. chronic pulmonary thromboembolism, vasculitis, and idiopathic pulmonary arterial hypertension, are included by some. Right ventricular failure is not necessary for a diagnosis of cor pulmonale. Physiology. The pulmonary circulation lies between the right ventricle and the left side of the heart. It carries deoxygenated blood, which takes part in gas exchange in the lungs. Blood flow through the pulmonary circulation depends on the left ventricle and respiratory movements. Negative intrathoracic pressure during inspiration sucks blood into the pulmonary circulation, while positive pressure on expiration pushes it forwards. The right ventricle acts as a pump only when there is obstruction to the pulmonary blood flow. Cor pulmonale is due to an increase in right ventricular afterload. This occurs secondary to an increase in pulmonary artery pressure, pulmonary arterial hypertension. Pathophysiology. Hypoxic vasoconstriction is the most common cause of pulmonary arterial hypertension, PA. Hypoxia may be episodic as seen in obstructive sleep apnea or chronic as seen in any other chronic lung condition. Once PA is present, there is an increase in right ventricular workload to maintain an adequate cardiac output. PA may be worsened by the increase in blood viscosity that accompanies polycythemia, which in turn is due to hypoxemia. It may also occur in some people who live at high altitudes and is known as chronic mountain sickness or Monge's disease. Clinical presentation. The symptoms of PA are nonspecific in the early stages of the disease and may not be apparent for months or even years. As the disease progresses, symptoms become more noticeable and include dyspnea, exertional initially, fatigue, presyncope or syncope on exertion due to inability to increase cardiac output during exercise, chest pain, may be due to ventricular ischemia, leg swelling, palpitations, cough, hemoptysis. In rare cases there is hoarseness of the voice due to compression of the left recurrent laryngeal nerve by the dilated pulmonary artery. In advanced cases, passive hepatic congestion may cause right upper quadrant abdominal pain and jaundice. Examination. Check for features of underlying conditions: edema, cyanosis, central and peripheral, tachypnoea, left parasternal heave, due to right ventricular hypertrophy, pulsatile hepatomegaly, splitting of second heart sound with accentuation of the pulmonary component, ejection systolic murmur over the pulmonary area, distended neck veins, with a prominent V-wave and a pansystolic murmur at the left sternal edge due to tricuspid regurgitation, occur in right ventricular failure. Pleural effusions are very rarely a feature of cor pulmonale, e.g. when associated with the underlying cause. Diagnosis. Perform the following to establish a case of cor pulmonale. FBC. ECG may show right axis deviation, P pulmonale, rhythm disturbances, and right bundle branch block. Arterial blood gases. CXR. Lung function tests. High-resolution CT scan. CT pulmonary angiography if recurrent pulmonary embolism is suspected. Overnight pulse oximetry may demonstrate nocturnal hypoxemia. Polysomnography if obstructive sleep apnea is suspected. Treatment. Treat the underlying condition, e.g. chronic obstructive pulmonary disease, diffuse parenchymal lung disease. Maximize oxygenation. Diuresis. Consider preventive anticoagulation, even if PA is not caused by thromboembolism.